everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. Today's episode is sponsored by Q Optics. Surgeons, your neck shouldn't pay the price for precision. It's time to demand loops that are built for you. Q Optics is more than magnification. Custom crafted through the lens loops engineered and tailored to your unique facial structure and surgical posture. The ultra lightweight titanium build eliminates pressure points, red marks, and the chronic neck and shoulder pain caused by heavy, bulky, outdated optics. With the exclusive True Fit measurement system, each pair is precisely tailored to your unique facial structure, delivering a customized, stress-free fit and all-day comfort. The Ergo Direct Vision loops with up to 60 degrees of declination keep neck flexion under 15 degrees, or go zero flexion with the Ergo Angle Deflection loops for a straight-ahead gaze and complete ergonomic relief. And with crisp, edge-to-edge clarity within an expansive peripheral view around the telescopes, your field stays wide and unobstructed. Transform your OR experience today with a 45-day trial and exclusive pricing for listeners of this podcast. Visit qoptics.com/Dr. Lal to learn more and schedule your demo with a local representative. And again, don't forget to use the code Dr. Lal to claim your discount. Your work demands precision. Your body deserves relief. Q Optics, designed for comfort, built for performance. By the way, Q Optics has also provided us with an Ergo Angle Deflection loops and headlight combo giveaway. The details will be provided at the end of this episode, so stay tuned. Hello, everyone, and welcome to another episode of the Surgical Ergonomics podcast. In today's episode, I'm really pleased to have as our guest Dr. Amin. She's a breast surgical oncologist, section chief of breast surgery at University Hospitals, Cleveland Medical Center, and co-director of the breast program at the Seidman Cancer Center. She is the Nancy and Donald Maltby Master Clinician in Breast Health and an associate professor at the Case Western Reserve School of Medicine. Hello, and welcome to the podcast, Amanda. It's great to have you.
Thank you for having me.
So, Amanda, when I have guests on the podcast, I usually like to kind of start off by having them tell us a little bit about themselves, including kind of, maybe where they trained and lived and how you arrived at your current role, just to provide some context for our listeners.
Sure, no problem. So, my background is I grew up in Northern Illinois, outside of Chicago, and I actually had a pretty linear path in my career. So I learned pretty early on that I thought medicine was pretty exciting, and that was really surgery for me. It wasn't, oh, we'll see how it goes. It was, I would like to be a surgeon. That felt like a good fit for me early on for whatever reason. And so I did my medical school training at Southern Illinois University. I had the honor of matching into general surgery at the Medical College of Wisconsin in Milwaukee. So I found my love of managing breast cancer patients in residency, and then I went on to do my breast surgical oncology fellowship at Northwestern in Chicago.
Okay.
After completing all of my training, my first job was at the University of Kansas in Kansas City. While I was there, I also obtained my master's in clinical research, where I was focusing my research efforts on the de-escalation of surgical management of benign and high-risk breast lesions. So that's something that I'm really passionate about. I was at KU for 7 years, and then I made the transition to my current role, where I'm in Cleveland. And you heard about my appointments and my academic appointment through Case.
Great. Thank you so much for sharing that with us. And I want to let our listeners know that I actually met Dr. Amin first. I think it was about maybe 3 years ago now, when Dr. Sharon Stein invited me to give kind of not like department-wide grand rounds, but I think divisional grand rounds relating to surgical ergonomics. And I think I had also gone to Cleveland for an AES meeting at the time. And that's where I actually had the pleasure of meeting Dr. Amin, and we had a wonderful dinner together along with a couple of other colleagues. And, this is where I kind of learned a little bit about Dr. Amin's story. And so I was wondering, Amanda, if you would be willing to share, how you became interested in surgical ergonomics and some of that story that you shared with me, because we all know, as we're realizing more and more, there's such a stigma attached to surgeons kind of talking about their injuries. And part of my, one of my goals with this podcast is to make people realize that it's more common than we think. And if people are experiencing work-related pain and or have had injuries, they're not alone. We don't talk about it, but it doesn't mean it doesn't exist.
Mhm. Yes, thank you for inviting me to share in this way, because as I was going through my journey, I can distinctly remember I didn't know anyone else like me
Mhm.
that had had the experiences that I had had. And so I felt, it felt isolating, and I felt like there must be something wrong with me that I've experienced this, because no one else in my peerage, or even, the people that trained me, I didn't know
Mhm.
about
Mhm.
them having injuries like this that had been challenging. So yeah, as a full-time breast surgeon, I was operating 2 days a week. I was doing, over 300 cases a year, because we do, multiple cases in a day. I was wearing a headlight for every case that I did, which started, into residency, and then through my fellowship and into practice. I know there's been a lot of conversations about lights recently on your podcast. And so I know there's this idea about passing on the
Passing on the pain. I think Joshua Mesrick and I talked about that.
yes,
Yeah.
yes,
And
but
I'm guilty of doing it. Yeah,
but I have to say I haven't done that, because I value the light so much that I have always worn my own headlight, even if others are. I
I
felt
see.
that I always wanted to see where I needed to see. I didn't want to be dependent on others shining the light in my space. So I have worn a headlight for every case that I have done since I've been in practice, and even,
Mm.
for my for my
Training. Yeah.
mentors who are training me too. So it's been a lot of pressure on my cervical spine throughout that time.
Yeah.
And, as breast surgeons, when we do breast conservation cases, we're oftentimes working through small incisions. The goal is to put our incisions in sort of, we use what we call hidden scar techniques, where we're not putting our incision right on top of the cancer. We're sort of tunneling to get to the cancer, which means we're oftentimes operating in sort of a twisted, orientation.
Hmm. Hmm.
And the headlights overhead are really not able to shine the light sort of deep into that dark tunnel using these small incisions. And
Hmm.
then when we're doing mastectomies, if we're doing breast nipple sparing, we're oftentimes working from an inframammary fold approach. So we're looking sort of up and over the breast mound, which really, really puts you in sort of some funny orientations
Yeah.
for sometimes an hour or two.
Hmm.
So I've been operating like this, my whole career. And and after one particular difficult nipple sparing mastectomy, I was doing a bilateral, it was in 2018. I noticed that I had some numbness on the right side on the lateral aspect of my right thumb.
Mm.
And I thought maybe that was from the pressure from my scissors, because I do scissor dissection, and I had remembered that being a particularly difficult case, but the numbness didn't resolve when I thought it should. So eventually, with my workup, I found that I had a disc herniation at C5, C6. And so I met with an orthopedic surgeon at that time. I really didn't have any motor deficits, and I really didn't experience a significant amount of pain that went along with this. Although I didn't really actually appreciate what nerve pain was. I think that was
Mhm.
something
Mhm.
that I
Mhm.
came to learn later. We just decided that, I didn't need a fusion, which I was relieved about.
Mm-hmm.
And but I also didn't recall receiving a lot of guidance about anything else other than I just didn't meet criteria for surgery. I didn't remember being referred to PT. I didn't remember being recommended for do these certain exercises or don't do these certain things. And so I
Mm-hmm.
just sort of limped along. And I remember having these flares, I'm a runner, and so I would experience pain sort of in my periscapular region and my scalenes
Mm-hmm.
when I would run or when I would do certain poses in yoga or when I would have difficult cases that would, sort of wax and wane. And I just thought that this was normal because I had probably been experiencing this even earlier than my diagnosis,
Mm-hmm.
certainly afterwards, but I didn't really talk to anyone about it or think that there was really anything to do about it. I felt like
Mm-hmm.
this is my life, and I would get massages, which could be helpful, but I didn't really find that there was a significant relief other than icy hot Advil.
Right, right.
So I just sort of limped along this way. And then in 2022, so I was in my new role here in Cleveland at this time, I
Mm-hmm.
I slept funny. And I woke up with a lot of neck and shoulder pain.
Mm.
And I was headed to a conference fairly shortly after this. And so I can remember being on the airplane and going to put my suitcase in the overhead compartment, and I couldn't physically do that. So that was my first noticing that I seemed to have a strength
Weakness. Yeah.
problem now.
Yeah. Now a strength problem. Yes. Actually, I remember you telling me about this trip. You were headed out of the country for
Yes.
a national meeting.
That's
Yeah.
right. And then I
Yeah.
had dinner that night. We landed and I rested, and then we went to dinner. And I realized when I would go to reach across my plate to pick up my glass of water, I had to support my arm to bring the glass of water to me. And so these were my clues that something is definitely not wrong, and I'm in pain. And so I did get through the conference. I came home. I had another MRI. And so now I'm herniated at 4-5 in addition to 5-6, and it's taken out my C5. And so,
In your dominant arm, of
right,
course. Yeah.
right,
Yeah.
in my right
I'll
arm.
point that out in your dominant arm.
Now, as a breast surgeon, I have to say it's actually a little bit lucky for me because that was my fine motor. And so if it had been my left arm, that would probably have been more challenging, which is my strength and retracting arm.
Hmm.
I
Hmm.
was still able to, continue to operate because I couldn't reach up and move the lights for myself, but the fine motor things I was able to do. But the first surgeon that I met with told me that I needed a fusion. I was really nervous about that because I knew that that would limit my range of motion. I know that that
Hmm.
puts additional stress above and below that fusion, and oftentimes people end up with additional injuries. And I'm young. I'm an athlete. I wanted to run again. I wanted to, I'm very early in my career. I felt like
Yeah.
there's
Yeah.
no way that I can saddle myself with this that would likely then have all of
Hmm.
these
Hmm.
implications for the rest of my life.
Hmm.
So I actually found a neurosurgeon that was willing to do disc replacements for me.
Placement. Okay. Hmm.
So I'm really grateful. This was really, I think it was approved for single level herniations. So I think I got a little bit lucky that I was able to have this done at 2 levels, but
Hmm.
it has been life changing, truly.
Wow.
So
Mm.
I then, after that was done, I would tell people I felt like that took years off of my life. The pain or the discomfort that I
Yeah.
was experiencing, I no longer had. And so that's how I was able to say, oh, I think that was actually nerve pain that I was feeling this entire time. And I don't have that anymore now that my nerve root's been decompressed. And so I have great range of motion, and I'm able to continue to operate. So that has been a game changer for me. And I can't say enough about how
You're
good
full
I
of
feel now that
gratitude. Yeah.
now that
Yeah.
that, that injury has been relieved.
Yeah. Wow. So, thank you. Well, first of all, thank you for sharing all of that. And it's really hard for us to share our kind of personal life details, let alone health details. So I really am grateful to you for doing that. And I think it will just help people to hear about things. Um, but you said a lot of different things there that I'm in the last few minutes that I'm going to try and unpack and
Mm.
we'll get into this a little bit more. So, I think for our listeners, I'll say, it doesn't matter if you've been following the podcast or if you're a new arrival to the podcast and you're just picking up a random episode. You'll see this theme play out over and over and over again, which is there is such a thing as surgical personality and surgical culture, right? So we will keep going literally until something breaks the camel's, cervical spine, shoulder, lumbar spine, something gives, right? We will keep pushing through because we show up for the care of our patients. There's also another part of that culture where we don't see people talking about it, as I mentioned earlier. Either your mentors, you mentioned your mentors, or your colleagues, other breast surgeons probably weren't talking about it. And so you feel alone, and that sense of isolation is very profound. I know I experienced that as well, and I've talked about it when I give lectures that it brings back those feelings of imposter syndrome as well, because you're like, were they right? I mean, I can't hack it in surgery, okay? Like they were right, And so it brings all these feelings back, which doesn't really help your recovery or your pain. It makes surgeons less resistant to, I should say, more resistant to reporting their pain, getting help early on, like you said, now you weren't given direction about PT and things, but let's say somebody had, you could have maybe intervened earlier, maybe. And we continue with by the grace of my willpower and Advil, I shall proceed, right? There's another piece in there. You came back from your foreign trip or from your international trip, and even though now you had weakness and you were planning to see another surgeon and get, advice regarding surgical treatment, you didn't stop operating. I heard you say, I was weak, but it was my right arm and I could just continue with my operating. So I just I'm repeating these things, Amanda, just to kind of reiterate the things we talk about on the podcast many times, which is, that we as a profession also have a lot of work to do. It's not fair to blame everything on instruments and, things like that. It's obviously a huge piece, but our culture is another huge piece. We made it this way, so maybe we have to work to change it. All right, now I'm going to try and unpack some of the other things that came up. So, as a specialty, you mentioned as a breast surgeon, you do certain, breast conservation procedures. So, if you're not doing a lumpectomy or a sort of simple mastectomy, then you're doing either skin-sparing mastectomy or nipple-sparing mastectomy, which is, I think, what you were referring to, especially as the need for prophylactic mastectomies happen more and more. Um, do you feel like there's a spectrum of procedures in breast surgery when it comes to ergonomic risk? I mean, I think I remember reading when I was delving into this topic for a coaching client a few years ago that nipple-sparing mastectomy is like the pinnacle of surgical workload and ergonomic risk. Is that correct?
I think it is, certainly. I mean, there's no way for me to position my body where I can
Hmm.
be looking straight at
Neutral.
what I'm
Yeah.
looking at, right? I have
Yeah.
to stand
Yeah.
with my hips flush to the table and then I twist with my spine to like look up into the chest.
Yeah.
And the goal is always making our incisions as small as possible that we can work through. So I walk up to the table and I measure the width of my hand, which is 9 centimeters.
I see.
That's as big as my incision so that I can get
Wow.
my hand in, right?
Wow. Okay. Okay. So yeah. It's it's interesting to hear you say that because it makes me kind of reflect back on my own sort of specialty, which is, endocrine surgery. And I
Mhm.
remember I think a lot of my left-sided neck face pain that I talk about is related to mini incisions.
Yeah.
So anything minimally invasive, whether you're doing laparoscopy, thyroid surgery, thoracoscopy, or breast surgery, anything minimally invasive is going to increase your risk of pain and fatigue. I mean, multiple studies show that. And for me, it was the same as you said, it's a smaller incision, so you have to apply more force to retract. And I
Mhm.
was often using a peanut and really kind of flexing
Mhm.
my wrist. And of course, I could feel my trapezius tightening up. And so now my incisions are a little bit bigger. They're 8 centimeters instead of 4 centimeters that I used to do
Right.
because I just can't retract that much. Now, you're fortunate in breast surgery a little bit that you don't have to use loops. That's a whole other thing.
Right.
But you mentioned a huge risk factor for many surgeons, but especially breast surgeons because of what you described,
Mhm.
headlights, right? So
Right.
headlights, by the way, for our listeners, have been shown in multiple objective studies. So when you have surgeons wear posture recording devices and you look at the time that they spend in high risk neck, torso, and shoulder postures, um, we can tell that if you're wearing a headlight, it's an independent risk factor for increased time in high risk neck posture.
Mhm.
So that doesn't come as a surprise. And so now I'm gonna ask you a little bit more about these headlights. So you've been wearing the headlight throughout training, and your life as an attending. You didn't pass the pain on like I did, as I discussed in the last episode, to the trainees because, like you said, you wanted the light a certain place. Did you try, at any point looking at alternatives to headlights? The reason I ask is I tried out lighted retractors from our breast surgery colleagues, because I was talking with them and they're like,
Yes.
well, we try these breasts. So I tried them for thyroid surgery and they seem to work pretty well. So tell me about all the things you tried and what have you learned for that other breast surgeons can benefit from?
Yes. So certainly making the transition from, and I've worn multiple different iterations of the headlight, right?
Yep.
We have the
Yep.
corded light, which,
Hmm.
in your last episode, you talk about like the whiplash that you can get as
Yes.
you get the call from pathology and you leave the table to go talk to them and you forget you're plugged in,
Yep. Yeah.
or you're burned with the cord when someone slips it into your pocket, like very unpleasant experiences with that device. And so then you have the battery pack one, but you still have quite that heavy halo.
Exactly. Yeah.
And so after my second herniation and surgery, I
Mhm.
upgraded myself because
Mm.
I'm a big girl now, to the light that can be fixed onto my glasses. So no, I don't wear loops, but I still have glasses that I wear. And so it's the same
Protective
light.
glasses. Okay.
So it's
So
the
you get
same
the
light.
same small light. Yeah.
Yep, exactly. So that's very, very light. And that then I have the small battery pack that I can wear on my waist, which disconnects me from the main light source. So that I has found has been incredibly helpful with minimizing the weight, the downward
Hmm.
weight on my cervical spine.
Yeah.
But you're absolutely right. There are additional lighted devices that we use. Um, I use them in addition to wearing
Got
the
it.
headlight
Yeah.
as
Yeah.
well, because
I
like
mean,
I
these
can't
are
get
all
enough light.
adjuncts, right? Like you've got to figure out what works for you. It doesn't work for everybody. So,
Right, right. So there are multiple iterations. What I have found is some of them are a little bit rough on the mastectomy skin flap. So I
flaps. Yeah.
typically only use lighted retractors on my mastectomies. But for lumpectomies, I typically don't, although, depending on the tunneling that you're doing, some people do.
Yeah.
But I found that sometimes they strip the subcutaneous fat off of the skin flap, depending on how aggressive your help is helping retract. So that has not been always a positive experience for me. So it's always
Right.
balancing, making sure that we're keeping the skin
Flaps viable. Yeah.
right
Yeah.
down. There's
Yeah.
also a lighted suction, which I have used all three at the same time sometimes. Because if we're,
I have seen those too. Yeah. Yeah.
yeah, with when we're using sort of a bigger cup size nipple sparing coming from the inframammary fold going all the way up to the clavicle is a significant distance that you're traveling. And sometimes it's looking around the gland,
Mhm.
because the gland is still intact sometimes as we're trying to take it off the muscle. So in anything that, can shed any light on that situation, I think helps us get the breast off and get the patient off the table.
Yeah. No, thank you for sharing that. I hadn't thought about the suction. I haven't actually tried that. So you've tried all of these things, but your favorite is still having a light headlamp now attached to your glasses. So for our listeners, I mean, you know this from experience, and others probably know this from experience too. So the thing about these headlights for people who aren't surgeons but might be listening to this podcast is that, as Dr. Mesrich described in our last episode, right? There's this headband, and so and then you have this cord, and even if you get a corded one, you have the weight that is adding to your weight of the C-spine. And then when you're wearing a headlight, you often have to flex the neck. So if you look at patterns of surgical injuries, the most common sites are the ones that Dr. Amin just described, right? It's C5, C6, and then C4, C5, and C5, C6, okay? So those two are the common kind of levels of injury. My injury is higher, so I have a bulging disc. I haven't herniated it completely, and it's on the opposite side of my neck pain, so I can't blame it for that. But my disc bulge is a little bit higher. So because I wore loops, so that made additional neck flexion, right? Not just the weight of the loops and the headlights, but you have some flexion related to the headlight, then you have some more forward flexion. And so it's interesting how you can see that difference among surgeons who wear loops and then those who wear headlights in terms of the levels that they can do. And I want to point out to our listeners, unlike me, latecomer to physical fitness, Dr. Amin was a runner. She was doing yoga. She was taking all, her care of her neck and body when all this happened. So the point is that you can't blame yourself or the instruments or whatever. All of us, there's going to be a nature and nurture component. Some of us may have underlying connective tissue disorders, and some of us may just have weak links in the body, and you may be physically fit, you may not be. This is just one of those things. It's that unique combination, whatever the forces that you're doing in your job and your underlying physiology, because people often tell me, well, I've been doing this for years and I've never had an issue. And I said, great, thank you. It's thank your lucky stars because, this can happen to anybody. So again, I want to emphasize you're not alone if this happens. And, you can reach out to me or any of the surgeons or people that have been on the podcast because they have all been open to discussing these things. Now, Dr. Amin, I will say I will connect you with Dr. Mesrich because now I want you to try his Mesrite, the
Interesting.
Meslite for breast surgery because I
Yeah.
want to hear how it works, for non-transplant things.
Hmm. Hmm.
So, okay. Now, let's kind of change direction a little bit. So you've had these injuries, and as you said, you're fortunate to be able to still work. What are your thoughts on what we can do as a specialty, like for your specialty, breast surgery, and even as I mentioned earlier, as a profession, what can we do to make the current situation of surgical ergonomics better? Where people don't talk about it, where we don't have curricula, at least not everywhere. How do we try to move the needle, and what efforts have you been involved in trying to move the needle?
Right. This is a great question. And I think the destigmatization of the
Mhm.
idea that we can be injured in our practice, I think is really important because I can remember talking to one of my older partners in my previous practice when I herniated my first disc, and she's like, "Oh yeah, I used to operate with some, old men that all had scars on their neck and they all had
Oh,
herniations by the end of
wow.
their career." And she's like, "Yeah,
Yeah.
that's an old man thing." She's like, "What's wrong with you?" I was 4 years into practice when I was injured. And so it definitely happens to
Hmm.
women
Hmm.
earlier in career. And we should be sharing our experiences and talking about opportunities to make changes. I have been delighted to actually see you in multiple different meetings. I think now the Association of Women Surgeons, I know that there's been presentations at our breast society meetings, the American Society of Breast Surgeons at ACS. And I'm sure you're going to, multiple other disease societies talking about your experiences and having, additional sort of ambassadors in these spaces for our individual diseases, talking about our experiences. So destigmatization, what are we doing that we now can continue in our careers? So how are we promoting longevity in our careers, either after an injury or injury prevention, all the way from the types of surgeries that we're doing, the positioning or length of incisions, our lights, our I know a lot of other areas are talking about, when they do laparoscopic things, the positioning of their towers and what they're looking
Hmm.
at,
Hmm.
all of the things about, body positioning in the OR, how we take care of our bodies before and after the OR, what are our physical activities that we're doing to keep our muscles strong. I As a runner, I hate weightlifting. I hate anything upper
Yeah,
body strength training. Super important though, if you
yeah.
to continue to, maintain your ability to operate, even though my operating doesn't require a lot of strength, like being able
Hmm.
to be physically well to maintain that stress on my body. I
Hmm.
must do weightlifting,
Hmm.
whether that's using body weights or actual weights. So sharing our experiences and sharing what has worked for us and having there really be um, society emphases, I think, so that it's advertising to each of the different specialties. We recognize that this is a real threat to our surgical field, for us to continue to take care of patients long term, well, health being well and healthy, and knowing that when we are not,
Hmm.
the patients potentially suffer, right? When I think back to some of the cases that I did
Right.
when I was maybe not at my best, it's a little scary for me because I don't like the idea that I potentially showed up and not at my best. And I didn't always recognize that I wasn't at my best until I was able to have a surgery that, helped me,
Yeah.
not be in pain anymore. But I mean, I definitely operated through pain. I definitely operated with a weakness and got through those cases, but that was not ideal.
Right.
So helping, I think, our younger people understand when to get help, when to say, is this right? Should I be experiencing these sort of symptoms after doing this? What should I, who should I talk to?
Hmm.
And taking some time off, having physical therapy, I think all of those things are going to be vitally important that we continue to stay healthy and well so that we can have, long, rewarding careers in these fields.
Right, right. No, absolutely. I'm just sort of thinking again about all the things, you so eloquently stated. So I keep harping on these things and I'm okay harping on them because so for our listeners, Amanda pointed out that, she was told, well, this is an old man's disease, and so I'll have everyone know, if you haven't heard me say this already, women are twice as likely to complain about musculoskeletal symptoms from operating. Some studies say even 3 times more likely to suffer injuries compared to their male counterparts in the same specialty. And it's not because we're weak, okay? Let's get that out of our heads. It's because we are built differently. A woman isn't a small man. So even if you account for height, we're just not the same. And this could be basically, you can broadly call it, we all have different anthropometrics, right? How things align in our bodies, how they work together. The width of your fingers matters as much as the hand span. It's not just, you can't just compare things by glove size. I'll refer people to the first episode with Dr. Susan Hallbeck for more details on that. But because of that, because of our varying anthropometrics, we need to find things from all the menu of options you'll find discussed on this podcast about how you can set yourself up in the OR for success, how you can take care of your body outside the OR, whether it's doing some sort of stretching and strengthening. You can do running, and it provides great sort of protection and improves your mental health and cardiovascular endurance. But if you want to be a surgeon, you have to find a way to stretch and strengthen. And like Dr. Amin said, you can do this with body weights. That's what I do. I can't lift huge weights with my trapezius anymore, but body weight stuff is just fine. Okay. So anything that you can do in that regard is fantastic. Now, since you brought up all these things, Dr. Amin, I'm going to ask you, do you take stretch breaks in the OR? while doing breast surgery? And what has been your experience trying to implement stretch breaks if you've tried implementing them?
Yeah, this is a great question.
Yeah.
I I can't remember. It's been several years since
Hmm.
the Mayo app I think became available. And when
Yeah.
it did, I don't remember. It might have been when you introduced it to us, when you came to talk to us a couple of years ago. So I can remember bringing it into the operating room and saying, "We're going to do this." I gave it to my circulator and I said,
Yeah.
press the button. I think it was every 15 minutes or something that
Yeah,
we.
every 45 minutes, but
What
you
was
can
it? Okay.
adjust. Yeah, you can
Okay.
adjust the time. Yeah.
Okay, yes. So clearly I am not doing it right now since I cannot recall exactly the details of it, right? And it didn't go well. Um, so I
Interesting.
liked it. I thought it was fine, but I think that the energy around consistently doing it
Hmm.
was not, everyone in the room was respectful of it. So I know that the buy-in was not the issue. It was just sort of seen, I think maybe as like one more thing that we had to do. And
Right.
everyone was busy, and it was the first thing to drop off as we were sort of like trying to get through our day, right?
Yeah.
And
Yeah.
the one advantage I would say in our space for breast, unlike, a transplant surgery,
Yeah.
some of
Yeah.
those big surgical oncology cases, is I'm doing multiple cases in a
Mhm.
day.
Mhm.
And I can, I spend, anywhere from an hour and a half to maybe 3 hours at the table for a case. And so if I'm doing, multiple breast conserving surgeries, I sort of naturally am already breaking, shortly after when the timer would go off to do a break. And so that's sort of my go-to break, is just get through the case and then I'm out the door again. But I think the idea of like engaging with the room, and I know that you've had someone else on who has talked through this, especially the scrub who experiences, it's oftentimes significant neck,
Mhm.
shoulder, back pain as a result of their position. And they don't have clinic on Sundays and OR on Sundays, right? That their job is to be in the OR 5 days a
Yeah.
week. They're lifting heavy trays, they're helping move patients. Like they have a very physically demanding job, and the value of them breaking and resting and resetting, I think, is incredible. And so the importance of engaging with your whole team for everyone's buy-in, I think, is critical. And I did not do that. And I quite honestly have not gone back to doing that. But it is something that I am interested in. And I have to say, the one time that I stop and remind myself is if I'm getting myself in a position in the case where I feel like I'm struggling and I can't see well, or I can't
Hmm.
quite
Hmm.
get something to happen. That is my pause of like, stop what you're doing. Everybody breaks, stretch for just whoever's retracting for me. I stop the retracting because I know if I'm, sore, they're sore because they've been holding and trying to show me what I need to see.
Right.
So everybody gets a stretch for a minute, and then we reset and we go back.
Awesome. So this is, thank you for sharing your experience. And that's why I had, Chris Krauser on a couple of episodes ago, because we've all kind of tried to implement in some way or another um, the Mayo Clinic app. And as I tell people, it's a great place to start. If you've never done breaks in the OR, this is like a set timer. You can adjust it if it's not a great time in the case. You can put a snooze, etc. But all the things that you just highlighted, I've struggled with the same. I didn't engage all the teams, I tried to do it in the OR, and I just ultimately, like you, realized that here's the thing. I'm going to take breaks when I'm feeling like the pressure mounting, both mental and physical. Step back, let everyone put, let the poor junior resident medical student put their retractors down as well. If I'm hurting, they're hurting, just like you said. And that's actually sufficient too, right? Taking a postural reset, however you do it, whether it's using an app or using your phone or when you're waiting for heparin to be reversed or waiting for a frozen section, whatever you want to do it, this is a crucial intervention that you can kind of do to reduce, mitigate the risk of injury. So thank you for sharing your experience with that. Yeah, we have a long way to go to implement ergonomic best practices, but we're way ahead than where we were 4 years ago, where we weren't even talking about it, right?
Correct. Yes.
All right. I say this all the time and I'll say it again. When we have these conversations, time just flies. And I realize we have a few minutes left, and I do want to touch on something with you. So, whenever I talk about ergonomics, often someone from the audience will go, just switch to the robot. It's way better. And I agree with them 100%. Well, let me take that back. I agree with them 90%,
Okay.
okay? Because the robot allows you to sit down at a console that is adjustable. You don't have to worry about the lighting.
Mhm.
You don't have to worry about your hands doing awkward retractions. Once you set them in, you can. But it has its challenges. The rates of lower back pain and injury are lower, but you still have neck pain on the old models. The newer models has helped that a little bit. The newer model has helped that a little bit. And you still have that problem of cognitive and physical fatigue, and you start seeing more hand wrist issues than you do with conventional laparoscopic surgery. And I remember I think it's Dr. Kopkash. She's looked a lot at ergonomics in breast surgery, and I'm hoping I'll have her at some point,
Yeah.
down the line as a guest. But do you do robot assisted breast surgery, or what can you share about your experiences with that with respect to ergonomics, or anything else you want to share about it?
Yeah, thank you for that question. This is, I think, certainly where this future of breast surgery is headed, or
Mhm.
at least I hope. I think that it's a really exciting opportunity. One of the fellows that trained at Northwestern after me, Dr. Deb Farr, is really leading this
I
initiative
see.
at UT Southwestern in Dallas.
Hmm.
My understanding with the robot as far as nipple-sparing mastectomy is concerned, which is really, where a couple of different trials are. Mayo has one. I think Ohio State used to have
Hmm.
one. They're not FDA approved for breast surgery outside of a clinical trial. So I don't think that anyone is just picking up the robot and doing this outside of
Got it.
a trial. And, for me, it's a little bit daunting because in the era that I trained in, this is really going to make me feel old. When I was a resident, the robot had come out for general surgery, and sort of in my last 2 years of training, we got a robot, and staff were trying to learn how to use it. And so the older residents, were sending the younger residents to those cases because we didn't want them to
Interesting.
do it.
Interesting.
All of the,
Yeah.
futzing around and learning that our staff were doing with their, those were not cases that we were going to be a part of. We were going to be,
Hmm.
on the sidelines, and we were interested in open surgery. And so I feel like that this feels very analogous to starting to do laparoscopic surgery, right? And the people who felt really comfortable doing open procedures are like, that's crazy technology that takes too long.
Right, right, right.
So I have truthfully never sat at a robot console before, ever. Because I didn't have that part of my general surgery training. And so for those who have and do some of these
Mhm,
procedures, they can't speak highly enough about it. And so
mhm,
that
mhm.
that is an exciting opportunity, but I know that there will certainly be a learning curve for those of us who just don't have that experience with that technology. But that said, we all picked up laparoscopic surgery in residency appropriately. And so new technology is exciting. And breast surgery is not an overly technically challenging field. I really love it for the aspects of cancer management, which
Mhm,
is
mhm.
a rapidly evolving space. And we do the procedures that are somewhat rote. So adding in a new technology to our surgical experience is also another, exciting opportunity
Yeah,
for
yeah.
those that are stimulated by these things. So I would love for that to continue to evolve. And I know
Oh.
that our hospitals are continuing to arm themselves with a army of robots. So hopefully we can get some time on it once that becomes, a little bit more of an approved approach. And the advantages are certainly that, the incisions can be smaller. beyond, all of the ergonomics for the surgeons, patients have a little bit more preserved skin sensation in some of the newer literature, which is also exciting. So potentially that's,
Mhm.
the trauma from the retracting, if it's gas insufflation, that potentially
Right.
is less traumatic to the skin flap as well, which may help preserve some of that sensation. So I think that there are unique opportunities with that technology beyond the ergonomics as well. So excited to see how that continues to evolve in our field.
Indeed, indeed. And no, you did not age yourself. The first time I did a lap appy was towards the end of my training, so in residency. So I went to learn robotic thyroidectomy, like I think in 2010, 2011.
Mhm.
And that's the time that the FDA actually pulled its approval for
Mhm.
robotic thyroidectomy. So, as you said, things evolve. And now, if you ask me, I'm not sure I'd go learn in a completely new technology. In
Mhm.
2010, I was willing to learn it. That being said, I have spent some time at various robotic consoles just to be able to coach people.
Mhm.
And I must say, yes, it is interesting. And I was excited to see the next version of the robot and notice the differences when it came, to the ergonomics. And so it seems that industry is also listening, right? All the feedback that they got regarding kind of the viewfinder of the first iteration then led
Right.
to a lot of the changes in the second iteration, or I should say in the most recent iteration.
Mhm.
With that, Amanda, I see we're almost at the end of our time. And so I do want to take a minute or so to again express my sincerest gratitude for the time that you have spent with me this afternoon recording this episode and sharing your story and sharing your perspectives. And for our listeners, I will share Dr. Amin's contact information on LinkedIn. And I'm sure, like many of our guests, she'll be open to anyone reaching out if they're have some questions about ergonomics in breast surgery and if they're looking for help, if they're having symptoms themselves. So with that, again, my most sincere gratitude. Please remember to subscribe to the podcast and follow us on social media, Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening. To enter your name for the Ergo Angle Deflection Loops and Headlight Combo giveaway, please go to our podcast landing page at www.surgicalergonomics.com/podcast/ and fill out the contact form at the bottom of the page. Choose Other in the drop-down menu and indicate Loops giveaway in the message. We will do a drawing for the winner in December of 2025, so please spread the word among your colleagues and friends who might be in the market for new loops. Thank you.